Welcome to this podcast on management of exacerbation of obstructive airway disease. We have a very special guest. It's my immense pleasure to introduce Dr. Ravindra Ghawat sir. He is the intensive care head at Jupiter Hospital with loads of experience in managing all kind of intensive care patients. Even when my father was admitted, he was taking care of him. So welcome sir for this podcast. This is basically a question answer session on management of obstructive airway disease, which we see on day in and day out. This is about the golden hour that we have when the patient walks into the emergency room and in the ICU. What kind of management we prefer to do. So first I will like to start off with the case. I'll tell you the case and then we'll have the question answer session. So it's a 67-year-old male with severe COPD, had passed 2 hospitalizations because of COPD in the last 1 year. On arrival, patient was tachypneic, saturation was 80% on room air. We did an ABG, we found it was acute hypercapnic respiratory failure, PCO2 was high. And in the ER, there was frequent nebulized short-acting bronchodilator given. And after an hour, he got slightly better. And now patient is planned to shift to the IC. So now let's start with the questions. So in such a patient who walks in, who knows he has COPD, who's had past history of hospitalization, what is the most important priority in the first 10 minutes?
So any patient who has got an acute exacerbation of COPD, it's a known COPD, the first priority becomes the airway. So usually what you look at is whether the patient is able to maintain the airway. What level of exacerbation he is suffering from right now when he is in the ER or the ICU. Whether he is using accessory muscles of respiration, whether the breathing is paradoxical, whether he is obtended, drowsy, how are the hemodynamics and the oxygenation. So this becomes the priority before looking at the CO2. And if the patient is not maintaining the airway, then you need to think about what you are going to do for maintaining the airway. If it's too obtended, whether you need to go for immediate intubation. If he's too hemodynamically unstable, or sometimes if they are in respiratory arrest and have an agonal breathing, so then you directly go to invasive ventilation. If the patient is conscious, not very obtended, is able to maintain the airway and only the respiratory distress is the problem, then of course you will investigate, but start oxygen so that you maintain the oxygenation well. Look at the clinical sign, look at the hemodynamics and then take it from there.
So as you said, the most important thing is clinical evaluation even before you take an ABG, and the results come within 15 minutes or 10 minutes. And based on the clinical scenario, you can take a call whether you want to straight away go for intubation or manage the airway with oxygen and nebulization as we did in this case. So the next question, what target of saturation do you aim for in COPD exacerbations, and what is the preferred initial oxygen delivery device in the emergency room?
So usually if it is an acute exacerbation of COPD, then saturations of, if like in this patient, he already had
80.
Yeah, history of admissions twice for COPD exacerbation.
Yes.
So here usually you target saturations of around 88 to 92%. Should be acceptable. But if it's an asthmatic patient, so maybe then 92 to 94 or 95%. COPD a little lesser target.
Less,
asthmatic little higher target.
And
so that is the usual saturation targets you would aim at.
What would be the preferred?
Unless and until the patient has ischemic heart disease, known ischemic heart disease, then probably your saturation targets might be little more.
Little higher. Yeah.
And if the patient is having arrhythmias, so if the patient is having active arrhythmias, then probably your saturation target should be little better than or more than what you are aiming at right now.
Okay. And how would you achieve? What is the preferred mode of oxygen delivery for such patients?
So depends on the patient comfort. Usual preferred is of course the oxygen mask, and ultimately what you look at is the achievement of target oxygen therapy, oxygen saturation. So you want to maintain the oxygen saturation. What device you use is usually immaterial. It depends on the patient's comfort. Usually patients would be comfortable with the nasal cannula. Some patients may not be comfortable with the nasal cannula, they will be more comfortable with the mask. So usually we would use mask because then you can also use nebulization through the mask. There are of course the Venturi masks available, and if the patient is not maintaining saturation, then maybe a high concentration mask. But ultimately, the target is more important than what device we are using.
Yeah, but you can also, as you said, you can give an oxygen-driven nebulization at that point.
Yes.
The mask can help to cover for both, giving the high oxygen also and the nebulizer. Just we have to
That's why
manage
that is an advantage of
giving a mask.
giving a mask rather
Just
than
make sure
nasal cannula.
PCO2 is not that high. So in the first hour in such patients, what is your bronchodilator strategy to rapidly stabilize this patient? You want to give short-acting beta agonist like salbutamol or ipratropium or a combination, or how do you start?
So usually the preferred one is combination, and it is a short-acting bronchodilators. Whether you use SABA like the albuterol or salbutamol, and ipratropium, that is the muscarinic anti-muscarinic ones.
Anti-muscarinics, yes.
So you can usually the combinations are better. People have used single dose, only the short-acting bronchodilators, and what various studies have found out that the combinations are better and they give you a better result, because you get results with both the. So you get a synergistic result.
Synergistic result, yeah.
So combinations are better, and in the initial few hours, if it's a severe exacerbation, you need to give them more frequently. People have given them even as continuous or every 10 minutes.
Every 10 minutes.
Ideally, what is recommended is every 20 minutes for first 1 to 2 hours, or till the patient is little settled. And then you can probably switch over to a less frequent dose, maybe 2 hourly or 1 hourly, depending on what the patient's response is.
Would you start with a long-acting one? Like many people use formoterol-based combinations in the ward. Would you start it in the emergency room?
In my practice, at least I don't start long-acting ones initially, because in acute exacerbation, what works is the short-acting ones immediately. And once the exacerbation settles a bit, once you have used the short-acting ones, then probably you can switch over to. I would rather use the short-acting ones more frequently and then decrease their frequency as per the response, and then switch over to the long-acting ones.
And
that is the usual practice.
If, let's say, people now, we are going to an era where we know that formoterol based combinations, though they don't act as quickly as salbutamol, but they do act pretty quickly. So would there be any benefit to starting them early, in your opinion?
Probably may not be in the acute exacerbation, but switching over therapy may be worse, and then probably they have lesser frequency of dosing, so that becomes an advantage for patients who are taking it for a longer period. And plus, obviously, as the time goes by, you would want to switch over to a therapy which is less frequent and longer acting, so that the compliance also becomes better. And at some point, giving those short-acting bronchodilators too frequently also becomes tedious for the healthcare workers as well. So if you have something which is longer acting and it's going to have a persistent effect, maybe there, bridging it after a few hours or a day or so, then probably yes.
Yeah. So this is pretty much what does happen. I mean, even as a pulmonologist, I would not be comfortable starting formoterol based combination immediately. But the first thing, we did discuss in one of our forums that before a pulmonologist gets a call from the ER, they've already given salbutamol and ipratropium. Sir, ये तो दे दिया है. अभी आगे बताइए क्या करना है. So sometimes we don't even get the chance to start the long-acting ones immediately. The next question is, do you start systemic steroids upfront immediately in the ER for all COPD and asthma patients who have come with exacerbation?
Not all patients. So if you actually categorize them into mild, moderate, severe, or you would say those who are not in respiratory failure, those who are in impending respiratory failure, and those who are in an respiratory failure. So somebody who has a respiratory rate of less than 24, saturations are 95, and you can just manage them with nebulizers, short-acting bronchodilators. I am not keen on starting steroids with all its risk involved. But moderate, severe, definitely yes. Severe asthma, severe exacerbation of COPD, definitely yes, upfront and within an hour, as early as possible. Moderate, again, I would wait for some response and see what the response is to initial bronchodilators and then give. But the dose should be 1 milligram per kg and not high dose.
So as we discussed, mild ones probably you might want to avoid. Moderate ones weigh the pros and cons if the patient is not responding to the nebulization. Severe and very severe ones who are having a respiratory failure, probably steroids would work in that case. Now, if I have to choose between an oxygen delivery device like HFNC versus an NIV in a COPD exacerbation, which one would you prefer?
COPD exacerbation, I would prefer non-invasive ventilation.
So NIV preferred, yeah.
NIV, because see, ultimately you want to offload the muscles as well, and which would happen better with NIV. HFNC, where NIV is contraindicated, probably very few situations. If the patient is not absolutely compliant or not comfortable, or there is some anatomical problem where you cannot use NIV, there HFNC. But by and large, NIV would be the preferred choice.
Yeah. So as we discussed,
except if the patient is in acute respiratory failure, mild one, and hypoxia is the predominant problem, right? And where you probably don't need to manage the CO2 too much, and it is the hypoxia which is a predominant problem. There probably HFNC
might work.
Where you would require very high oxygen, FiO2s.
So if I have to put it, like most of the patients on NIV and very few selected on HFNC.
Very few. I mean.
Yeah. So you have to work of breathing needs to come down, and NIV works better than HFNC. The amount of PEEP NIV can give is much better than the HFNC part. Now, maybe sir, you have started the oxygen, you have given the nebulizer. What clinical parameters will tell you that the patient is stabilizing enough? Now you can cut down your nebulization frequency.
So lesser use of accessory muscles of respiration, the breathing pattern becoming more abdominothoracic rather than thoraco-abdominal. If the patient is generating auto PEEP in asthmas, sometimes in COPD, some amount of hemodynamic stability, the respiratory rate settling down, the saturation maintaining on minimum oxygen, maybe less than 50% or 40%. Diaphoresis decreasing, patient is not obtunded, more conscious, coordinating with the breathing better. Those should be the signs where you would feel that now things are looking better.
So you can cut down the frequency of the nebulization. As said, you give initially maybe every 20 minutes, you can give a continuous nebulizer. So those frequency can cut down if you see the patient is breathing better, is more conscious, can communicate with you. The best and simple thing is you ask a few questions. How are you feeling? If the patient is able to speak in a full sentence, I think that is good enough to tell you that he is got better. He or she has got
the respiratory distress
is less. Yeah. So now patient,
that would be a very good test if he can complete one
sentence. Yeah, that I mean specifically this thing helps in areas where they don't have big ICU setups like we have in Jupiter. So maybe a smaller setups, that will be a very simple test to do rather than repeating an ABG after some time or so. So now the patient looks a little better clinically, but at what point do you decide the patient is clinically stable and doesn't need to go to the ICU from the ER and can go to the ward?
So again, as I said, if he is requiring minimal oxygen, which can be given through nasal canal, doesn't require any oxygen. His pH is compensated, though you don't expect the CO2 to become normal, but at least the respiratory acidosis, if he had, if he was moderate respiratory failure or moderate exacerbation to severe exacerbation. So pH, which is almost compensated to more than 7.35 with whatever PCO2. No respiratory distress, patient should be conscious, hemodynamically stable, and with all other parameters good, and as you said, clinically, if he can complete 1 or 2 sentences, talk, communicate well, can eat his food or take something on his own, is mobilized, and that would be the time when he goes out of the ICU, he or she.
So this criteria can also be used for shifting from ICU to ward, where patient is stable enough, not requiring much oxygen.
Any emergency department.
Any emergency department, ICU or ER.
The respiratory rate less than 24, saturation maintained on minimal oxygen to more than 92% or around 92%.
Yeah.
Or whatever, standard 88 to 92%. Sometimes they would require a portable machine with a BiPAP, rather than non-invasive ventilation. Means non-invasive ventilation with a portable machine. With that.
Yeah, so but a patient who's requiring that probably would first from ER go to the ICU, stabilize on NIV, convert to a portable BiPAP and then shift to ward.
Yeah, depending on the requirement. Not all patients we would put them on portable BiPAP, So if they maintain, as I said, if they maintain the pH with PCOD, they are not fatiguing after some time. They don't go into exacerbation or become breathless after a dynamic challenge like a walk test or something. Then probably they would not require portable non-invasive ventilation. But yes, those who have frequent admissions, those who have like chronic COPDs and then they get exacerbation, these patients would require. Asthmatics rarely require a support with portable BiPAP.
So unless they are like chronic
unless
asthmatics
they-
become
yeah, they
COPD and all.
become-
So maybe younger patients probably will not have so much of an issue. They get better. So now we have availability of like we give salbutamol, ipratropium. We can add budesonide. We have combinations, various. We combine the two respules and give. We also had formoterol budesonide combinations and glycopyranum. We used to combine them to separate respules and give. Now we have a triple drug where we have glycopyranum, formoterol, budesonide in one single respule. Advantage being it's a single respule. The liquid quantity is less. It takes lesser time to give. And we prefer it in OPD many a times because that becomes simpler for the patient and the staff to handle. But would you think such a combination would be helpful in the emergency room where they are long acting and it's a combination single respule?
So I'm not sure. I mean, I would think that this would be more useful when patients are reasonably stable, or as a bridge therapy when you want to switch over from short acting bronchodilators and the SAMAs, and then you want to switch over to a longer acting therapy where you want to give once a day dose or twice a day dose, and which can be given by a nebulizer as well. Then you want to avoid those meter dose and powdered inhalers multiple times. The compliance becomes problem. And if you have something which like in the morning you take once, all three together in one small volume nebulizer for whatever 10-15 minutes or 20 minutes and then be relaxed for the whole of the day. In acute situations, they require the spasm and the exacerbation is so much that they require very short ultra-acting drugs.
Quick acting ones,
Quick acting, ultra-acting, quickly acting, faster acting, and where you can give repeatedly and you want to maintain that level. So when you have a once a dose, you are actually not sure about what level of the drug would be maintained, and what level of bronchodilation it will maintain for a longer period. So in an unstable patient, probably I would not be
too keen on.
But then yes, as a bridge therapy, I said in 24 hours patient settles down, because if you have once a dose and you have combination of all three together, rather than giving too many times nebulizations, one time steroid, one time this bronchodilator, one time something else, you have a combination and single dosing or twice dosing, nothing like it.
So that has been the experience with us also. Even pulmonologists have been like, this is something which is available simpler. Caregiver care from the caregiver's perspective, very simple. From the patient's perspective, one formoterol budesonide and
fantastic
glycopyranum you give separately. It takes half an hour, 40 minutes to give one nebulization cycle. Here it gets finished in 15 minutes. Cost saving is there, but starting it in emergency room is something which probably we haven't done, and we will be skeptical unless we get enough data to see whether this is going to, actually. Also, sir, I mean, a patient who is that breathless may not even take enough volume of air. The nebulizer, when you're giving, the drug might be just wastage. So, fact, frequent nebulization in such cases with short acting.
In fact, that is the dictum, and that is the reason why you give short acting and so frequently. Because most of the drug or quite a few amount of drug gets lost.
Just wasted outside,
It doesn't reach. It doesn't reach the areas where you're supposed to reach.
Actually, So, in your early experience with these drugs, where do you see this role in ward phase management of exacerbation? Like if you have a combination, like we give formoterol, budesonide and glycopyranum twice a day, we can mix it and give. There are people who give it separately. They get separate formoterol, they give separate budesonide, and they try to give a separate glycopyranum. Or you take a combination. In ward, is it helpful?
It would be fantastic to have a combination. because of two good things, I would say. One is the compliance in terms of patient, and the second is compliance in terms of the caregivers.
Caregivers, yeah.
Extremely important, rather than wasting time in giving that every frequently, too early, 4 early, 6 early, or you have 3 drugs which you are giving at different times, and you have only one drug which you give as a combination. The compliance definitely becomes. This is very common, with antihypertensives. Patients who are on many drugs, and usually they are not compliant when multiple drugs have been used. So that's why people came with this combination of antihypertensives. They put 2 to 3 things together, and the compliance becomes extremely well. So if you have something which is longer acting and you can dose them less frequently, and the compliance really becomes very good. And you have a combination where you get synergistic effect of everything.
So I think the missing link here up till now was probably, can you combine them in a single rispule, and probably that is what has been achieved. And that's a very good comparison with antihypertensive. Same happened with my father. He used to take 3 times in a day, and he would probably miss his doses. And then the cardiologist said, okay, I'll cut down to 1 tablet. He was very happy. But in the end, it was actually a combination of medicine which actually he was giving, and patient compliance gets better.
The only hitch is that all those drugs which have been combined together, they should be sort of compliant with each
compatible with each other. That is something which probably this is out of our area of expertise. The pharma companies have
many times you want to combine the drugs, but you are not able to do it because they are not compatible. So
I hope they have done enough data here. Up till now, patients have been happy with the triple drug combination. Only thing is, you probably won't use it in an acute setting. Probably when you're shifting to ward and shifting home on nebulization, there is where the role lies. So with this, I want some take-home message while managing the exacerbations of COPDs and asthmas that you have.
So most important is take care of the oxygenation. Don't miss a severe exacerbation. If you have to intubate the patient, you have to intubate the patient. In a patient who is not able to maintain airway, if he is not able to clear out secretions, he is distressed, diaphoretic, not maintaining saturation, in spite of giving 50 to 60% oxygen, please intubate. Don't get afraid of intubation. If these are the situations, the patient is having arrhythmias, hemodynamically unstable, extremely drowsy, extremely fatigued, pH is less than 7.2, PCO2 with whatever PCO2, oxygen is not maintained, as I said, then you intubate. If the patient is conscious, able to maintain the airway, please do non-invasive ventilation and avoid intubation in this type of patients. And in most of the time, in fact, if you use non-invasive ventilation, 70 to 80% of the time you would be able to avoid invasive ventilation. If you use good non-invasive ventilation, continue with the bronchodilator therapy, short-acting bronchodilator. In severe exacerbation, give steroids. Don't give higher steroids. And of course, at the same time, you need to rule out the causes and find out what is the cause of exacerbation, whether it is infection, whether it is an ischemic heart disease, or also look at and rule out any other condition which can mimic exacerbation of COPD like pulmonary embolism, a pneumothorax, and so on, even a pneumonia, and so on, or pulmonary edema. So these are the common ones. And then the closely monitoring is very important. So whenever you have a patient with moderate COPD, if you treat them well, or even a severe exacerbation, if you are using non-invasive ventilation, you need to continuously monitor them for most important obtundation, desaturation, development of pneumothorax, and hemodynamic instability. At any point you find this, you have to intubate the patient or act fast. So that becomes very important when you are putting the patient or managing them with non-invasive ventilation.
Yeah, so very well said, sir. So the management of COPD exacerbation is not just the drugs that you give, it is the clinical assessment, maintenance of oxygenation, the decision to intubate, not to intubate, whether to give steroids. We have seen many times, as sir said, don't give high dose steroid. We see 1 gram of methylprednisolone given in casualty. Those are not the drug to be given. And obviously look out for any mimics which are there. If you want to give nebulization, you've decided that this is a COPD exacerbation, You have managed the oxygen part by giving either nasal prongs, NIV, or a mask. You can go with the next step of nebulization. Start with short acting ones, and the patient stabilize, either shift to ICU or ward, and there probably you can step down to long acting ones or a combination one, whichever patient is comfortable with. So thank you, sir, for coming and joining us for this small session but an important session on management of COPD exacerbation. Pretty common condition. Many a times these exacerbations are managed at the family practitioner's clinic initially. So that becomes their ER. So this information probably will help them. And then obviously at a big hospital or a corporate hospital level, managing them and shifting to ICU or ward, what are the steps to be taken? Thank you for telling us with your experience.
For them, at the nursing home level or the OPD clinic, the most important thing is to look out for signs of distress. Yes, and when they should know when I need to shift this patient to a higher center.
Yeah.
Because you might miss the boat if you delay the things. So it is very important to take that decision when to shift the patient. No? And you must look for all these things, especially a patient who is obtunded. The patient is desaturating and is not responding to initial therapy of short-acting nebulization for a couple of or half an hour to 1 hour or maximum 2 hours. If the patient is not responding in the OPD or your clinic,
nursing home level,
or nursing home, you should shift them to
an ICU.
And then if required to higher center. Or at least to the ICU.
At least to the ICU. I absolutely agree with you. Thank you, sir. Thank you for those messages.
Thank you for having me here, Mehul.
Thank you.